Sollis. Better insights for better outcomes. This session was recorded live at our Advances in Population Health Management workshop in London, November 2018.
Next up is my good friend, colleague, Alan Thompson from Johns Hopkins Healthcare. He's currently the Director of User Support there, formerly a registered nurse and a senior manager in the NHS, so he's from both sides. And Alan offers insights from Johns Hopkins Healthcare work both in the UK but also globally. We, Sollis, have been working with Johns Hopkins for the best part of 10, 11 years, I think, now, Alan. I won't steal your thunder, but why we wanted to work with these guys is, just what it says on the tin, it's Johns Hopkins. There's some big brains at work here. They've been doing some brilliant stuff all over the world. We took a view that, well, why couldn't we do all that global stuff and make it work in the UK? And with Alan's support, hopefully we've done some way to doing that. So, Alan, thank you for 10 years of fantastic collaboration, and floor is yours.
Okay, thank you. So much to say and so little time to say it in, and some of this is a Johns Hopkins view, some of it's a personal view. I was a nurse, as Nigel said. I did my training at the Royal Free, just on the other side of the river. I love what you said, Steve, about it's about the population, but then it's about the cohorts or the segments, but most of all it's about the individual. And I strongly believe the real difference that you make to a person's health, which you can then multiply and affect a segment of the population's health, is by intervention with that individual. I would also echo what Dawn said about its whether we use the word patient or person. I don't think it really matters, but what I would add to what's been said already is my own view. It's about the person and their carer and their families, because often people don't have the capacity to manage their own health on their own, and they rely really heavily on what their how their families can support them as well. Three quick slides. As Nigel said, we are a global brand, but over the last probably 12 or 15 years, the ACG system, the risk stratification and population segmentation system that Nigel and Sollis use and other CCGs use, has been adapted for use in the UK. It is used around the world. The privilege I've had in the last 3 years that I've met people from all over the world who use the ACG system but are also interested in population health analytics and population health management. I've learned an awful lot from them, but what I would say to people in the NHS is they are learning as much from us as we're learning from them. We offer a great deal to the rest of the world, and they're always interested in how we run our health services. We do come from, or the ACG system is born from an academic background. It's been developed over the last 30 years. There's continued and ongoing research and development of the system as a piece of software, and that's led by the Johns Hopkins School of Public Health. And the other thing that I will build upon what you were saying at the beginning, Nigel, is yes, we produce a piece of software. Yes, it's being used by 45 CCGs around the UK and hopefully a lot more. But we're as interested in helping people understand the outputs of that software, and more recently much more interested in helping people do something with that intelligence and with those insights. I've had the privilege of being in Baltimore for a week earlier this year and spent a lot of time talking to the population health management team there, and they use this model, and I can't point to anything, so but it's a really simple model, and it's kind of a bit more macro than the kind of things that Dawn spoke about, and I think the kind of huddles that you have is a component of the overall model. But the model starts in the top left-hand corner. It's about the collection of health data. I would have to say that the quality and completeness and comprehensiveness of healthcare data in the UK and in the NHS is far, far superior to what they have in the US. So everything that they do, we can do, and then more so. But they do have a very rigorous process that starts with understanding how their population looks, what the distribution of health and risk is across their population at all levels of the population. They use the ACG system as one of their tools, but it is one of the tools, and they supplement that with additional information. And then moving sort of down to here, they then undertake this secondary process and looking at what other information and intelligence they have that would help them decide what segment a person might be in, whether or not they're, God forbid I use this word, Steve, impactability. But I suppose the key thing that I learned from them is that they readily accept that 80% of a person's health is determined by social factors. So a huge amount of their assessment about an individual and what care program they're going to develop and what kind of care interventions they're going to give is driven by social determinants of health, not just individual diseases. I suppose a similarity and a difference between what we do and what they're doing in Baltimore is some of it is about aligning the right patients to the right care programs, using the data that they have about those people. But some of it is about developing new programs of care based on what the data analysis is showing them and segments that they identify that might have needs that are not currently met by individuals. And a lot of that focus increasingly is on social and neighbourhood and non-health related needs, and it's about preventing ill health, maintaining the health of the population, promoting healthy lifestyles. And some of the programs of care they've set up are community based, and it's about people within the community, volunteers that are paid a small stipend, to actually work with their community and support individuals. And it could be as simple or as fundamental as helping somebody fill out a form, or helping somebody read a letter from the hospital, or helping somebody apply for free transportation to get them to the medical facility. But I suppose the other thing that I find really different, and you mentioned OBH earlier on, Steve, a lot of focus on understanding outcomes that they're trying to achieve for each of those segments of the population, developing outcome measures that make sense, things that they can measure, monitoring that, and then evaluating the effectiveness of those care programs and tweaking them. And that's a process that's repeated on a quarterly or more often an annual basis. And I loved it as a model. It's simple, but I suppose the things that probably appeal to me most is it's a very holistic approach. It is about the whole population. It is about segmenting and managing different segments in the population, but it's also about the individual. It's joined up, it's coordinated, it's actively managed. I've said it's repeated on an annual basis. And it is that mixture of looking at existing care programs and making sure that the right patients are matched to those programs, but also about looking for gaps in care, whether it's health care or whether it's social care, and actually developing interventions and care programs that work for those groups of people as well. I'll skip this, but it was really just to highlight that data. Oh, actually, no, I will talk about it a little bit. We did some work with Slough CCG, supported by Sollis. Did some work, and I think the original exam question was, which disease drives risk and drives cost and drives utilisation more than anything else? So we did a very comprehensive piece of population health analytics, and the answer was, we can tell you that it's probably heart failure that is associated with hospitalisation more than anything else. But actually, as soon as you start to look at couplets and triplets of disease or multimorbidity, the risk and the utilisation increases incredibly. So they took that as a new piece of insight. They said, well, what do we do? What can we do to support patients with multimorbidity that we're not already doing, because we have a very disease-orientated approach to provision of care? So they developed a complex case management service, and this was about 3 years ago now. They used the ACG tool. We developed a bit like in Croydon, we developed some case-finding techniques to identify patients with certain combinations of conditions where the GPs themselves said, with a little bit more time and a little bit more resource, we have the skills and the capability to manage those patients within primary care, and they don't always have to go to secondary care. bit like you were saying, Dawn, the case finding became less complicated because there was a structured case finding technique that they used. It allowed them to focus on patients, and in year one, amongst that cohort of 500 people, they saw more than a 33% reduction in emergency admissions, and since then it's for each cohort they're treating, the sustained reduction is about 18%. And the model is really simple. It's about identifying the patient, inviting them and their carers in for 30-minute consultations every 6 weeks for a 3 to 6 month period, measuring outcomes, and this satisfaction amongst patients and their carers has been measured both qualitatively and quantitatively. But interestingly, the GPs and the people in the GP practice who support these people feel more satisfied as well. Sorry. So really, I suppose all I'm saying, I suppose the key message is it was a really simple supplement to what they were already doing, but it's had a really big impact because it was patient focused or person focused. So that and that was derived from population health analytics and insights, but then actually doing something different as a result of those insights. Thank you for listening, and I'm around all day if anybody wants to chat to me at coffee break or lunchtime.
Thank you.
For more information and insights, visit our website, sollis.co.uk.